Welcome back. A reminder to submit questions for our Q&A panel through Slido, which you can find on the conference page on netrf.org. Our next speaker is Dr. Jaydira del Rivero of the National Cancer Institute. She serves as the principal investigator of the Natural History Study for neuroendocrine tumor and adrenocortical cancer. Dr. Del Rivero leads neuroendocrine treatment trials at the NCI. She's going to talk today about tackling unusual NETs.
Hello, everyone. My name is Jaydira del Rivero. I am a medical oncologist and an endocrinologist at the National Cancer Institute of the National Institute of Health. Continuing with knowing your nets, now we're going to discuss about tackling the unusual neuroendocrine tumors. Throughout the day, you have discussions about what neuroendocrine tumors are, where they are located, what means when they're well differentiated or more poorly differentiated. But now we're going to talk about those more unusual nets that they're also very uncommon, but also can have many different clinical manifestations as well as complications. As we discussed earlier, and as you have learned throughout the day, neuroendocrine tumors can be anywhere in the body. The most common locations is the small intestine, pancreas, as well as the lung. But there are other locations that are more uncommon, but is still part of the neuroendocrine tumor family. For example, in the thyroid, we have a neuroendocrine tumor of the thyroid called medullary thyroid cancer. Medullary thyroid cancer has the capacity to produce hormone called calcitonin, and we're going to talk a little bit about that. We're also going to discuss about thymic neuroendocrine tumor. You have heard more about lung neuroendocrine tumors, but maybe not as much as thymic neuroendocrine tumors, and we'll discuss a little bit of how we manage thymic neuroendocrine tumors. Briefly, I'm going to discuss about another very uncommon neuroendocrine tumor of the adrenal gland called pheochromocytomas and paragangliomas, as well as discuss briefly of more uncommon and rare neuroendocrine tumors that is localized in the genitourinary tract. And we're going to talk what that means and where exactly located. It's important to understand that depending on where the neuroendocrine tumor is located, then patients and the tumor can produce very specific hormone, and that hormone can lead to different clinical manifestations. Throughout the day, there was a discussion about what is the classification and grading of the neuroendocrine tumors. Well differentiated neuroendocrine tumors can be anywhere from grade 1, 2, or 3, depending on the Ki67. And where is the Ki67 is the proliferation index. It tells me how the cells are able to be divided under the microscope. Neuroendocrine carcinomas are more rapidly growing tumors. The Ki67 is more than 20%, but usually more than 55%. And this is an area where there is a need for more treatment options, but also to understand that neuroendocrine tumors and neuroendocrine carcinomas are completely different and are also treated differently. Neuroendocrine tumors that I originally mentioned, like the thyroid neuroendocrine tumor, the adrenal neuroendocrine tumors, as well as other sites like the genitourinary tract, which affects the kidney, the urethra, etc. They can also have different differentiations. And it's important also to understand that because depending on the differentiation, then there's going to be specific therapies associated with the neuroendocrine tumors, as well as different therapies depending on the location. In terms of the most uncommon neuroendocrine tumor, for example, medullary thyroid cancer, medullary thyroid cancer can also be part of the multiple endocrine neoplasia type 2A and type 2B. MEN2A and 2B also has another neuroendocrine tumor as part of the clinical manifestation, which is pheochromocytomas and paragangliomas. Bronchial or thymic neuroendocrine tumors are also being associated with MEN1, as well as pancreas neuroendocrine tumors has been associated with other cancer predisposition syndromes such as MEN1, von Hippel-Lindau, or NF1. Neuroendocrine tumors of the adrenal glands, such as pheochromocytoma and paraganglioma, also has been associated with other cancer predisposition syndromes like MEN2A, MEN2B, VHL, which is a von Hippel-Lindau, as well as neurofibromatosis stuff type 1 or the paraganglioma syndromes. And I know that I'm saying a lot here, but something to keep in mind, and it's important also to acknowledge that only 10 to 20% of patients that have neuroendocrine tumors may be associated with a cancer predisposition syndrome. And most of the time is the pancreas neuroendocrine tumors, not necessarily the small intestine neuroendocrine tumor. Another aspect is that usually in these cancer predisposition syndromes, there are other clinical manifestations that help us suspect that. Meaning that if you have a pancreas neuroendocrine tumors and no other clinical manifestation, it doesn't mean that you may have this cancer predisposition syndrome. But if there is other clinical manifestations known to be associated with different syndromes, that's when there is a suspicious and further testing is needed. Multiple endocrine neoplasia is a rare hereditary condition that is characterized for tumors of the parathyroid gland. So the tumors of the parathyroid glands are responsible for regulate the calcium in the body. The parathyroid glands are located in the thyroid. MEN1 also has tumors of the pituitary gland, and the pituitary gland can also produce certain hormones, and with those hormones can also produce certain symptoms, as well as pancreas neuroendocrine tumors. That said, there are other sites of neuroendocrine tumors associated with MEN1. We are learning now that despite the classic characteristics of MEN1, which is parathyroid, pituitary tumor, and pancreas neuroendocrine tumors, now we know that there is other neuroendocrine tumors also associated with MEN1, such as thymic neuroendocrine tumors, bronchial neuroendocrine tumors, stomach. There are other neuroendocrine tumors associated with MEN1, and is associated with a germline mutation in the MEN1 gene. And germline means that the mutation is everywhere in your body, and it has the capacity that that mutation can also be presented in your offsprings, on your kids, and so forth. As we discussed, a very common clinical manifestation of MEN1 or multiple endocrine neoplasia type 1 is the pancreas gastrointestinal neuroendocrine tumors, and is the second most common manifestations in patients with MEN1. These pancreas neuroendocrine tumors can have functioning tumors, meaning that they can produce hormones, or non-functioning, meaning that they cannot produce hormones. And as we discussed earlier, depending on where the neuroendocrine tumor is located and depending on what hormone that neuroendocrine tumor produces, patient can present with a very specific clinical manifestations, and we're going to talk a little bit about that. Patients that have MEN1 with the associated Zollinger-Ellison. Zollinger-Ellison is a neuroendocrine tumor that produces excess of gastrin. We also call it gastrinomas, which can be found in the small intestine as well as in the pancreas. Gastrinomas, but the pancreas are super, super rare that they can't be present there. Most of the time is located in the small intestine. 25% of patients with Zollinger-Ellison are associated with MEN1. So if there is a patient that may have neuroendocrine tumor that produces excess of gastrin, it's indicated that patients need to be tested for this MEN1. Now, the thymic and bronchopulmonary neuroendocrine tumors are uncommon in MEN1, but it can happen. In MEN1, up to 8% of patients may present with a thymic neuroendocrine tumors, and patients in lung neuroendocrine tumors can also be present in less than 5% of patients. And most of the times are non-functional, because throughout the day, and maybe for another podcast that the Neuroendocrine Tumor Research Foundation have, lung neuroendocrine tumors can also produce hormones, and those hormones can also produce a very specific clinical manifestation. These thymic or bronchial neuroendocrine tumors, when the hormone is produced, they can produce either excess of serotonin, causing a carcinoid syndrome, can produce excess of ACTH, and this hormone is responsible for stimulate the production of cortisol in the adrenal gland. And that condition is called Cushing's syndrome. And we'll talk a little bit about that and what does that mean. In terms of the treatment related to MEN1 related tumors, as we discussed, pancreas or small intestine neuroendocrine tumors can present as functional or non-functional. As we discussed, functional meaning that it can produce hormones, and depending on what hormones the tumor produces, there may be certain specific interventions needed or treatments needed for that. And in terms of the thymic neuroendocrine tumors, as we said, most of the time are non-functional. Usually when the thymic neuroendocrine tumor is located, those patients may require surgery and sometimes may require radiation. And patients with MEN1 can be quite rare, but they can also be serious. The same with lung neuroendocrine tumors. Sometimes when they're located, sometimes surgery may be indicated, but if not, there are other interventions. These lung and thymic neuroendocrine tumors in a patient with MEN1 can also spread out to other places. And in those situations, that's with more systemic therapy is indicated, as you've heard throughout the day. Stomach neuroendocrine tumors, that's the one that it produces excess of gastrin, the hormone that is responsible to regulate the acid in the stomach. If you have too much gastrin, then you have a lot of acid in the stomach, and that can also cause a lot of complications, including bleeding and ulcers, or what we call peptic ulcer disease. There are other rare places that patients with MEN1 can have neuroendocrine tumors, and those are such as a small bowel or the adrenal gland, as we discussed, but that's very rare. When this is present, there are treatments, and those treatments need to be discussed in a multidisciplinary team to determine what is the best for those patients. As we discussed, thymic neuroendocrine tumor, what is functional, can produce either serotonin, and this excess of serotonin can cause carcinoid syndrome. And throughout the day, you also heard that small bowel neuroendocrine tumors can produce excess of serotonin, and sometimes there are certain drugs needed to control not only the growth of tumors, but at the same time, the excess of hormone or the symptoms related to excess of hormones. But let's just talk a little bit about these hormones that I know is very unique hormone. It's called ACTH. It's a very long name, but the information for this hormone is that it can stimulate the production of cortisol in the adrenal gland, and because of that, it can cause syndrome called Cushing's syndrome. It can be present not only on the thymic and bronchopulmonary neuroendocrine tumors, but it can also be associated with the pancreas as well as adrenal, thyroid. So this condition called Cushing's syndrome is something that can happen, and sometimes it's occult. And that's something that when the excess of cortisol is present, the symptoms can be also quite obvious, but it's something that needs to be acknowledged and recognized. What are the symptoms of Cushing's syndrome? As we can see here, there are many clinical manifestations. Most common clinical manifestations that we see a patient with Cushing's syndrome is the purple stria. There is also an increase in fat of the abdomen as well as the back of the neck. Easy bruising as well is present, thin skin. There's also very clinical characteristics and fat called moon face. This excess of cortisol can increase the blood pressure, can also cause hyperglycemia, can also cause some personality changes, depression, and those are a series of symptoms that related to Cushing's syndrome. And like I said, this happened because there is an excess of cortisol, and there are treatments that can be given for the excess of cortisol. If the neuroendocrine tumor is localized, like for example in the lung and thymic neuroendocrine tumors is localized, then surgery is indicated. Sometimes they require oral medications in order to control the excess of cortisol. One of them is ketoconazole, one of them is thiropon. So there are different oral medications needed to control the excess of cortisol. And that we see in patients that has more like widespread disease. In those situations, the removing the adrenal glands is indicated because you remove the stimulus of producing the excess of cortisol. Now let's discuss a little bit about medullary cancer and what medullary cancer is and what this type of neuroendocrine tumor do. Medullary cancer arises from a very specific cells in the thyroid gland called C cells. And this type of C cells is also responsible to produce a hormone called calcitonin. It helps regulate calcium levels in the body. When there is this excess of calcitonin, patients sometimes can also have a series of symptoms. Medullary cancer, in about 75% of the cases, is sporadic, meaning we don't know how it happened. But in 25% of cases, it can be familial or hereditary. And when that happened, the gene that is associated with this hereditary medullary cancer is called the RET gene. And this is important to know because if we have a patient that had clinical manifestations or present with medullary cancer, then it needs to be tested for this gene responsible for the syndrome called MEN2A or MEN2B. As we can see here, when it's hereditary, MEN2A can affect the parathyroid gland, can also cause medullary cancer, and it can also be associated with pheochromocytomas, which is another type of neuroendocrine tumors localized in the adrenal gland. MEN2B is a little different. The similarities is that they can have pheochromocytomas as well as medullary cancer, but they have very specific physical manifestations, tall and lengthy, that's called Marfanoid bodies, and sometimes they can present like a little neuromas in the mouth, for example, and that is characteristics of MEN2B. As I say, when it's hereditary, is because there is a tumor gene associated with this MTC, and this gene can also be present not only on the germline, causing hereditary MTC, but also in 50% of sporadic MTC can also be present in the tumor, which is different than in the germline. So red gene plays a role in familial medullary cancer, but in patients that we don't know the cause, in sporadic MTC, half of those patients may have that mutation. And why I'm mentioning this, because there is specific medication, drug that specifically targets that red mutation. And that's important to know. When it's localized, surgery is usually what is indicated. And sometimes in the thyroid, they also remove lymph nodes near the thyroid as well when the MTC is spread. So there are different medications. Selpercatinib and prasetinib those are the medications that targets the red gene. And again, it's important to recognize they can be hereditary, and most of the times are associated with familial syndrome called MEN2A or MEN2B, and that is a germline red mutation. But also in 50% of patients that have MTC, that we don't know the cause, it can be only in the tumor, meaning it's not hereditary. That's why patients that have medullary cancer, it's important that they do genomic testing in the tumor to be able, if the patient is eligible for these specific therapies that target that specific mutations, which we know it works well for patients. Now, very briefly about genitourinary neuroendocrine tumors. What are the possible neuroendocrine tumors of the GU tract? It could be in female, it could be the cervix, the uterus, the ovaries, and male, it could be the prostate. But there's also neuroendocrine tumors that can affect the bladder, the kidney, the ureters. These are very rare type of neuroendocrine tumors. But also these genitourinary neuroendocrine tumors, some of them can be well differentiated, but a good number of these genitourinary neuroendocrine tumors may be more poorly differentiated. And as we discussed, there is a difference between neuroendocrine tumors as well as neuroendocrine carcinomas. It's important to diagnose earlier. There is different imaging and biopsy in order to determine the type of neuroendocrine tumors. There are different treatment options, such as surgery, chemotherapy, targeted therapy. But that said, it's important that when a neuroendocrine tumor is diagnosed, to have a discussion with a multidisciplinary team in order to understand what treatments may benefit the patient the most of the treatments that we have available. Now, here, very briefly, in terms of the management of neuroendocrine tumors, we have a variety of drugs. And throughout the day, there has been discussion of what drugs we can use or what kind of therapies we can use in patients with neuroendocrine tumors that is widespread. You have heard about PRT throughout the day and the monthly injections called octreotide lanreotide. These injections are important because not only help control the growth of tumors, but also help control the symptoms related to hormone excess. And in patients that neuroendocrine tumors is diagnosed and there is some growth, the question is, do we continue with these injections? And we continue as long as the tumor is functional, meaning it can produce hormones, because like I say, it can also help control the symptoms related to hormone excess. There are different targeted therapies such as everolimus, sunitinib, cabozantinib, you have heard throughout the day, as well as when to use chemotherapy, and as well as when to use surgery or a very specific type of therapy in the liver. It's called ablation or embolization. I'm just mentioning this because, as we can see, we have treatment options for neuroendocrine tumors. When do we need to know what treatment is indicated for each patient is depending on the site of neuroendocrine tumor. So we discussed the more rare type of neuroendocrine tumors. We also need to know whether they are slow growing or rapidly growing, because treatments are different too in that aspect, or if they're well differentiated or poorly differentiated as well. We also need to understand whether the tumor expresses somatostatin receptor or not, so that way PRT can be an option. We also need to understand where in the body it's localized, whether it's only in the liver or if it's outside the liver. So that way it can help us guide what is the best therapy for a patient with neuroendocrine tumor. So we really need to account the clinical characteristic of each patient, because it's not a one size fits all. So the treatment is quite personalized from patient to patient. Now let's discuss a little bit about pheochromocytoma and paraganglioma. And this is a neuroendocrine tumor that is very close to my heart. That's how I started in the field of neuroendocrine tumors, by studying pheochromocytomas and paragangliomas. Pheochromocytoma is a very rare type of neuroendocrine tumors that forms in the adrenal gland. As we can see in the picture, are located on top of the kidney. If we cut the adrenal gland in half, it has two layers, as we can see in the picture, and the inner layer is what we call the adrenal medulla, and that's the part that is responsible to produce excess of adrenaline. And this excess of adrenaline is responsible for the flight and fight response. Paragangliomas are located in different nerves throughout the body, could be anywhere from the head, chest, abdomen, and pelvis. Depending on where they're located, they can be functional or they can be non-functional. Pheochromocytomas and paragangliomas, when we look at all together, most commonly we see pheochromocytomas, which are located in the adrenal gland. Most of the pheochromocytomas, like I say, functional, meaning that they can produce excess of hormone, but also paragangliomas located anywhere from the head, abdomen, and pelvis. It can also be located in the neck area. Most of the time, they're non-functional because they come from a different type of part of the nervous system. But when they're located anywhere from the chest, abdomen, and pelvis, often they're functional, meaning that they produce hormones. And these excess of hormones can certainly cause a very specific symptomatology. Now, every patient that has pheochromocytomas and paragangliomas needs to be evaluated by a genetic counselor. And the reason why is because up to 45% of patients that has pheochromocytomas and paragangliomas may have a germline pathogenic variant. And as I discussed earlier, the difference between germline and somatic, germline is everywhere in the cells and it has the capacity to pass to your kids, whether somatic is only in the tumor, and that's not hereditary. But every patient with pheochromocytoma and paraganglioma needs to have a genetic counselor. If we see a patient that have a paraganglioma of the head and neck, sometimes we think, well, there may be a mutation indicated with that, which we call succinate dehydrogenase mutation D. If we have a paraganglioma, that can be anywhere from the chest, abdomen, and pelvis. There is another mutation associated with that, which is called SDHB. The reason why I'm saying this is because patients that has more advanced disease and that has widespread, often we see an association with this mutation, especially SDHB. There are very specific symptoms related to paraganglioma. As I said, very rarely are non-functional, and that's usually when it's localized in the head and neck. But when they are functional, with this excess of hormones, can produce many different symptomatologies such as flushing, palpitations, abdominal pain, blurry vision, tachycardia. The most classic symptoms that we see in those patients is high blood pressure, headaches, and sweating. And because of that, there are medications as well that can help us control the symptoms related to this hormone. We can see here there is different medication that is used, and it's important to recognize that there is treatment recommended to address the symptoms related to excess of hormones, but also there are treatments indicated whenever we need to control the growth of tumor or when the patient has a widespread disease, so there are different therapies for that. And this is my last slide that in terms of the treatment of pheochromocytomas and paragangliomas, very similarly to what I discussed for neuroendocrine tumors and the more uncommon size of neuroendocrine tumors, it's also personalized from patient to patient. Depending on the different clinical characteristics, similarly to other neuroendocrine tumors, we need to know whether the tumor expresses somatostatin receptor, whether they can rapidly growing or slow growing, where it's located, whether it's on the head and neck, or whether it's in the abdomen. Sometimes surgery may be indicated in order to control some of the symptoms related to hormone excess, sometimes by resecting the tumor. Sometimes that can help also minimize some of the hormones, and that can also help decrease some of the symptoms related to hormone excess. But that say is not for everyone. And like I discussed earlier, treatment is personalized and needs to be discussed in a multidisciplinary team with surgeons, interventional radiologists, and endocrinologists, oncologists, so that way we can formulate a plan that we think it will be best for patients. And my conclusions: unusual NETs are rare, but they are treatable. They can appear in places like thyroid, thymus, the genitourinary tract, as well as the adrenals. Early diagnosis and close follow-up matters. We imaging studies as well as lab tests, including hormonal evaluations when it's indicated, and sometimes genetic testing to help guide care. There are many treatment available for neuroendocrine tumors, such as surgery, different oral medications, chemotherapy, as well as PRRT, as we discussed, which is a type of systemic radiation. More importantly, is to recognize that you're not alone. Neuroendocrine tumor care involves a team of endocrinologists, oncologists, surgeons, nuclear medicines, gastroenterologists, radiologists, and also very important support groups. NETRF is a wonderful organization where there is a lot of material where you can refer to in terms of all the different type of neuroendocrine tumors, and also to understand more about how these tumors present and what are the treatment needed. And there is a lot of information where you can go back and understand when surgery may be indicated or when systemic therapy may be indicated. So I think it's important that rely on your support groups as well as the information out there from different support groups, as I say, like NetRF. And also ask questions, always ask questions, stay informed. Knowledge is power. Every neuroendocrine tumor is different, and understand your type help make the best decision in terms of your treatments. And with that, I would like to thank you for your attention.